How do you feel about the term lay midwife?
Here's the thing. The term lay midwife there is such thing as a lay midwife, but it's not what people think that it is. Hospitalist groups, doctors from different places coming in, and they would say, home birth transfer's coming, the lay midwife is bringing, and I would say, well, who's the midwife? And they would tell me, and I'd be like, no, she's not a lay midwife. She is a certified professional midwife, licensed midwife in the state of Washington. She's got lots of education. Do not call her a lay midwife.
I'm just confused by the definition because honestly, I've heard it used for CPMs, doulas that are acting as midwives, have no formal training. It's very confusing.
I feel like that term is used by OBs or medical providers inside the system in a very condescending way. And it's like, we're not going to recognize this person's education, letters, any kind of ability, and just call them all lay midwives because we don't recognize them as care providers in the first place.
Welcome to the Keeping Your Power Real Talk on Resilience podcast. I'm your host, Tracidoula. I'm a family and birth advocate, a mentor, and your personal encourager. I wanted to create the space for individuals, families, and professionals who are done with just surviving and want to rise. Because when everything feels like it's falling apart, the one thing the world can't take from you is your power. And that's where resilience begins. It's not just riding the waves or surviving the storms. It's about how to overcome the challenges. So whether you're in the thick of it or reflecting on where you've been, pull up a chair and let's navigate the hard conversations and the beautiful stories that together we can be honest and use empathy and have a desire to grow, all while, of course, keeping your power in the process.
Hi, everyone. Welcome back to Keeping Your Power, Real Talk on Resilience. I'm your host, Tracidoula, and I am sitting down today with two of my very favorite midwives, but they're my favorite people too, for many different reasons. I've known both of them for several years and have watched them in their midwifery practices. And this episode is really important to me because I feel like in specifically the birth world or in maternity care, we are kind of in a spectrum of a black and white thinking. You have some really weird things happening in the medical care system with people being ignored when they go into the ER, even in labor and those kind of things. So we're seeing some craziness inside the system, but then we're also seeing this, free birth thing with Free Birth Society and that article coming out and those kind of things. And there's always a middle to every conversation that has to do with birth with me. But when we talk about home birth specifically, it's very confusing, I feel like, to just the general public of we don't know what this means, especially if you grow up only having people that have gone inside the system. So I'm excited about talking to y'all about your positions and your education and your philosophies and how you handle emergencies, how you feel about it, because we have to remember that each midwife practices very differently. Not everybody is going to practice the same, just like OBs. So what I want to start with is tell us who you are and, what title you hold in your educational background. Whoever wants to go first can go first.
I'm Miri, and I am a midwife. My education is that I have a bachelor's degree in midwifery and did the apprenticeship model. So following around another home birth licensed midwife and learning from those people, I followed several different preceptors. And my training all in all lasted 3 years, and I took the NARM. That's like the big test for us. And then I had to go get licensed specifically in the states that I work in. So I'm licensed. I'm a licensed midwife and a certified professional midwife. So kind of how it goes is you pass the NARM, you get your CPM, and then you have to get licensed in the state that you plan to practice on. And different states have different licensing requirements. I'm licensed in Washington and Idaho.
And you own your own practice?
Yes, I own a licensed birth center in Washington. And we primarily do birth center births, but we also do home births occasionally.
Thank you for being here. I'm so excited.
Yes.
Thank you. Okay,
Yes.
Kim, you're up.
Hello, I'm Dr. Kimberly Taylor. I'm a certified nurse midwife and certified professional midwife. I became a midwife through nurse midwifery school. So I was a nurse first and then went and got a master's degree in nurse midwifery, which made me a nurse practitioner. I went back and got a doctorate degree in nursing. And I do hospital births, birth center births, and home births. I've been a midwife since 2018 and currently own my own practice who offers birth center births, home births, and hospital births in Montgomery, Alabama. So
the wide array of what y'all do is just absolutely amazing to me. How do you feel about, and either one of you can answer this, how do you feel about the term lay midwife? What does that do with your brain?
Gives me so much anxiety. So here's the thing, is the term lay midwife, I feel like I wish we could just like, kind of like I tell people, like, I wish they would take the mucus plug off of the internet. Like, that's a thing. You know what I mean? Like, get it out of the way. Like, I don't care about your mucus plug. Please don't put it in a baggie and bring it to me and like whatever. Right. But also there's a time and a place to talk about the mucus plug. Right. And like, so it's kind of the same exact thing to me as far as like the terminology lay midwife, because the way that I grew up as a midwife is there is such thing as a lay midwife, but it's not what people think that it is, right? And so so I've worked as a midwife in several different states, and Washington State is one of them. And I was in Olympia, Washington, and I was in a hospital practice there, and some of the like hospitalist groups, you know, you get a bunch of doctors from different places coming in, and they would say, you know, oh, a home birth midwife or a home birth transfer is coming. The lay midwife is bringing. And I would say, well, who's the midwife? And they would tell me, and I'd be like, no, she's not a lay midwife. She is a certified professional midwife, licensed midwife in the state of, you know, Washington. She's got lots of education. Like, do not use that. Do not call her a lay midwife. Right.
Because most of the time, I feel like that term is used by OBs or medical providers inside the system in a very condescending way.
Condescending way.
And it's like, we're not going to recognize this person's education, letters, any kind of ability. We're just going to group them all into the same space and just call them all lay midwives because we don't recognize them as care providers in the first place.
Right. And saying that they don't have prenatal care just because they weren't getting prenatal care in the system, right? So,
Miri, how do you feel about it?
Yeah, similarly. I mean, I'm just confused by the definition because honestly, I've heard it used for CPMs. I've heard it used for like birth keepers that have no training, no formal training. Doulas that are acting as kind of midwives. I mean, it's very confusing. And it's funny because actually where I practice, I'm well respected in the community. I transfer well into the hospital. A lot of them know me well over there. And so when I get reports back from the hospital, because they don't know what to call me, they don't want to call me a lay midwife because they know my practice is like they respect what I do. And so they put in on all their reports, Miriam Halliday, CNM. And I'm like, I'm not a CNM. No, instead of calling me a lay midwife, they don't understand anything else. So it has to be a CNM.
Yeah, because there can't be another type of midwife, heaven forbid.
Right. Yeah. Right. In the state of Alabama, when we were, working on legislation on those kind of things, and we educate, it still comes up. And I'm thinking we're making headway, and it still comes up every once in a while. And they're like, well, the lay midwives. I'm like, no. No, and I just Googled it, and Google even says a lay midwife is a maternity care provider who, unlike a certified nurse midwife, leans through informal training and apprenticeship rather than formal medical education. And that's not even an accurate description. I think that I just get hung up on the condescending attitude of, we don't really want to know what you do. We're not willing to sit down and really figure out what your education is because it's not our education. So we're just going to all lump sum you into the same. And my goal really, for specifically this episode is I really want to educate people on what midwives they can look for in their area, what questions to ask, and what really matters in their care because of these definitions that are out there that might be circulating that are confusing people even more. Even on the last episode when I'm talking to a lost mom who, her child passed away because of a shoulder dystocia at a home birth, she called her midwife a lay midwife, which was not a correct depiction of her midwife. So I think it's very important for families to have all of the information so they know, like, this is where my belief system is with birth, but we can't just say, hey, just go have a home birth and just blindly trust what everybody has been saying. And then we can't blindly accept what the medical system thinks about midwives either. That's very unfair also. When somebody comes to you and they're like, hey, I want to have a home birth, what is your system? Like if you get an inquiry that says, hey, Kim, I'm due whenever, and I want to set up a consultation with you, what does that look like? What do you know? What do you want to know from them?
Well, I ask them why. Like, why do you want to have a home birth? What makes you feel like that's the right thing to do for you? Because I want to hear their philosophy. I want to hear, is it just because, I had a terrible experience in the hospital and I think it's going to be better at home? Or are they scared of the hospital? Or, do they truly feel safer at home? Right? Because I'm not going to do a home birth for somebody who's trying to run away from the system and they don't actually feel safe at home, but they don't feel safe at the hospital. You know what I mean? So working through that, I want to know those things. I want to know what their fears are. I want to know how does their family feel about that? Like what's your support system look like? So those are my first three questions is about philosophy, like who, what, when, where, why.
Miri, how about you? What would be like a good, now we're not talking medical yet, that's category 2, but what would be a good psychological candidate for you, do you believe?
Yeah. I mean, I always go over the fact that we are not, if you're looking for ACOG standard of care, then you don't want a home birth midwife, like genuinely. So I want to figure out why they're choosing us. So same, like it's very important to me that I figure out that they understand what midwifery care is and that is something that they truly want and are advocating for themselves. And it's not something that they've been pushed into by, my mom had home births, or I just know people that have had home births and it was a better experience for them. And I've heard all these horror stories from the hospital. And I'm like, okay, well, you can have a great hospital birth. Let's talk about it. But I don't want you picking me because you just heard something or because you just found me on social media and you like how I present myself. Yeah. Like it's, yeah. Mm-hmm, yes. If it's an aesthetic thing, my birth set is pretty. And so people walk in and they think, this is way nicer than the hospital. Right. But I'm like, this isn't a good reason for you to pick this place. Yeah. So it's very similar questions for me too. It's really figuring out why they're choosing us and if they are invested in it, because I do think it takes a little bit more work on their part as far as education, informing themselves and doing the work.
It is not just about showing up at a birthing center or staying at home and having a really good outcome. It's about preparation. It's about understanding your need and interviewing well. And that's what we're talking about today, because I have heard so many people that are like, people were just telling me to go have a home birth because I had this really bad traumatic hospital birth, and it just ends up not turning out well. I will tell the people that get to me that want to debrief their births or whatever we're doing to prepare for the next birth, I will absolutely say, do not jump ship from a traumatic situation, do not choose a home birth, or don't choose a hospital birth because you had a really bad home birth situation. You've got to understand your own belief system and where you feel the safest and why things happened. Just because something happened really traumatically in the hospital does not give anyone free reign or license to just do the other thing. And I will see that on social media all the time. We'll just have a home birth. Well, that's why I choose home birth. This is exact reason why. Well, that's why you chose the home birth. But that situation should not make everyone just think, oh no, this is not the place that I need to be for this birth. And let's say home birth is not for everyone. It's not going to be for the ultimately high risk people. It's for the low risk people and, whoever wants to answer that question. And would that be different per midwife and who fit well with their practice? I mean, is there a foundational standard for home birth, but then would that matter per midwife?
I mean, I think it does vary per state. Actually in Idaho, we have a BMI rule, which I flatly think is awful. I want that changed in the legislation, but you can never have received chemotherapy in your life. There's some very strict rules in Idaho. Washington is very different, but I do think it will depend on the state. You can't have had any thyroid issues. And I take people with hypothyroidism, if it's managed and stuff. So I do think it can vary depending on the state legislation for sure.
Yeah. I think there are some fundamental ideologies too between midwives too. I'm pretty strict about my home birth criteria. And others will consult with me and I will say, why are you having a home birth for this person? Why is this okay to you? And they will not have an answer. So they'll find the gray area and say, well, it says I have to consult. It doesn't say they risk out. And I'm like, no, they risked out. And so, there can be some philosophical, oh, it'll be fine. Or, I'll say, well, what are you going to do about this situation? Because this is the protocol that we should be doing. And they'll say, oh, well, I'll just tell them the signs and symptoms to take them to the doctor or take them to the ER. And I'm like, sounds good. Sounds like not something I would do.
Yeah. So do you think that's more of a philosophy thing or an education thing, or maybe both?
Maybe both. I guess if you don't know that would be the protocol, then I suppose. But I think it has something to do with, I'm more on the end. I don't do home birth or bust. You know what I mean? And there are some who will push it to the edge to be able to give that, in the name of autonomy, right? So I have heard that multiple times. Well, that's what the patient wants. She understands the risks. She understands, our limitations or whatever. And so in the name of autonomy, that's going to continue. Whereas I do agree with that.
That only works with good informed consent, right? Or refusal. So yes. if somebody's interviewing and they don't know what they don't know, then you might feel like my midwife's good with everything that's going on, but you might not know that there's something that you should be looking for.
Well, that's kind of where your consent forms come in to me. I have a consent form for everything. And in the beginning of the, journey, before they even consult with me, they get my consent form. That's 11 pages long.
It is. It's lengthy. I've seen it.
And it's very long. It talks about, what education and training that I have, what education and training my other midwife has, what to expect philosophically wise, right? What the expectations are for, I don't carry this. I do carry this. You have to initial by, 6 pages worth of, I understand that my house doesn't have an operating room. And if there's an emergency, it's going to take time to get to one, just very basic things, that you would think would be common sense, but are not common sense. So, then there's going to be access issues, that there are, time constraints, there are strict criteria. If you have this, you will not have a home birth. If you have this, you will not have a home birth. So they get that stuff from me before they even have their consult. And then they have to sign initial by every single thing. Now, whether or not they read it, I mean, they do. I don't attract people who don't. So they read it. But, sometimes you come across the folks that are like, oh, I mean, yeah, like I read that, but like I didn't read it, But that, I feel like consent forms come in handy when it comes to those things.
Miri, you can answer this one. Have you ever been asked what your transfer rate is? And do you love that question?
Yeah. Nearly every consultation. I don't know if it's something in the water, but
we're on the internet, but they're just saying, what do I need?
It's probably a Google question, or they've asked ChatGPT or so. I don't know what it is. But I've been getting that question a lot. I also wonder if it's because if they do follow me on social media, I do post about my emergencies, like in a HIPAA regulated way. I don't divulge any specifics and identifying information, but I utilize a lot of my cases as opportunities for people to learn and know what midwives would do in an emergency. I think that a lot of midwives are fearful to post that they have emergencies. I don't know if that's true, but just because we are under scrutiny more, I think, and so we want to perceive to everyone that everything's hunky-dory over here at the home births, but it's not always the case because birth happens. But yeah, I don't like the question because I think I could give them a number. My number this year would be high, probably higher than my fellow midwives right now. It doesn't tell the stories and it doesn't tell the clinical decisions that were made and the right calls. I mean, I always say, a transfer is not a failed home birth. It is a birth gone right. The midwife made the correct calls to look at the situation and say, we do not have everything we need, and we need a higher level of care, and we need to go to that higher level of care. So yeah, it's frustrating because it feels like it's missing. The question is asking for a number, and that number is often missing the full story.
Well, it's the perception that a transfer is a failure. And a transfer is just help in a turn, a navigation to whatever that is. And I don't like asking a physician their cesarean rate. Same idea. I don't like, that's not what we're asking. It's more like you're asking, was this a birth that was just hunky-dory going the way that it needed to go? And then somebody said, okay, we need to transfer. It's more philosophy is what I feel like people are diving into, but they don't know how to ask those questions. So I feel like people need to ask more, why would you transfer? In what situation would you feel comfortable transferring, or you would feel uncomfortable and need to transfer? Because I've been in situations where I'm like, I hope somebody is calling 911 soon. Or, on the other side saying, oh, we don't need to go yet, in the back of my head, because it never will come out my mouth because that's not my role. In that topic, what would you love the question to be asked more than, or what do you feel like parents want to know in that question?
I feel like the question that I want them to ask is, what do you consider an emergency? What are some of the most, we take low risk moms and babies to prevent anything major happening, right? But emergencies happen in birth. Parents know that. And what are those things? And how would you handle them? Because then you're able to hear the midwife's thought process. And that tells you if your midwife has never even thought about how she would handle a hemorrhage, or if she even thinks it's an emergency. I mean, if you read that article about Free Birth Society, oh, moms can just bleed and then get up and walk away and be fine. So it helps you to figure out what is your midwife's philosophy on how she's going to handle those emergencies and what would be a reason to transport. And And that's what you're really wanting to know. You want to know, is my midwife going to recognize concerning signs and also transport me in a timely manner to somewhere where I can get more help?
Right. And are the signs going to be not suppressed? Because there can be warning signs, and you have the spectrum, right? You have the spectrum of midwife going, we're good. And then you have, those over here that are like, the very first sign, I want to transfer. So I do feel like it's a spectrum of education, skills, philosophy that definitely needs to be broken down. Kim, what do you feel like is your top emergency that it's gonna set you back into therapy for a while?
Another cord prolapse.
No.
Yeah.
And
those are real.
Just the really rare things that happen that can happen, right? And that don't normally happen. And then when they do happen, you're like, oh my gosh, really? We're doing this. All right, we're doing this. So, which is why having trust, that relationship, it's so important. I get really nervous when people switch really late in their pregnancy from hospital or another practice into home birth. And I don't have time to really get that relationship going where they they know me and I know them, and we can trust each other, and in that process be able to, she knows that I'm doing the things, and I may or may not be talking right that second, but she knows that I'm not talking because I got to do stuff, right?
Right.
And that I'm talking through things, but I don't have to be very thorough because it's okay. We already talked about these things before. So that's something that we'll probably talk about in a little while, but for me, we have a 36-week home visit. So 35, 36, 37 weeks. We come to your house, me and my team, and we have a labor rehearsal kind of visit where we don't just talk about the what it looks like, what labor looks like. That's your childbirth education. My education is, what are the emergencies that we might come across? Okay, it's getting real. We are term. All right, let's practice these things that could happen. Right. And so we're going to go over, I don't care if it's your first baby. I don't care if it's your 10th baby. We're going to go over the maneuvers for shoulder dystocia. What that looks like, what you're going to hear me say, and when you need to be serious, and when you hear me say, hey, do this, then you're going to do it. Right. And if this happens, then we'll do this. Right. We're going to go over neonatal resuscitation and all the things that could possibly be reasons. And sometimes there's no reason. Sometimes they just come out and don't cry. Right. And we're going to put this baby down. We're going to start breathing for them, blah, blah, blah. We're going to practice. We're going to show them what that looks like. Right. We're going to talk about a postpartum hemorrhage. We're going to talk about, okay, what does that look like? My threshold for postpartum hemorrhage, for bleeding, right? So if I always tell them okay, I've got herbs. Totally. We can do that. But guess what? Herbs take 20 minutes. If I know I need 3 to 5 minutes, you're getting a shot. You're getting it. You know what I mean? That's how that works. Right.
Yeah.
And I'm going to say, hey, you need that Pitocin. And most of the time people are going to go, okay. You know what I mean?
Yeah.
And because they know that I don't have it depends on how far away from the hospital they live, if we're 45 minutes away, you getting a shot, if you're 5 minutes away, I might entertain your shenanigans and give you the herbs and rub your belly. But if it keeps going, you're getting a shot. Right. So, we're going through those things, and then we're talking about those rare complications, like the cord prolapse, like a accidental breech birth, because it's not legal here to plan a breech birth here in Alabama. So I definitely check to make sure their baby's head down at 37 weeks, whatever. But we all know that sometimes those babies flip whenever in labor or whatever. And if their baby's coming out, breech. Okay, what are we going to do? What are we going to do for, we're not doing VBACs at home. So, that's not really a thing. I mean, we're not talking about uterine rupture, but we are talking about symptoms that they should be worried about, right? Preeclampsia, postpartum preeclampsia. So all of those things, those are have already been discussed. They have already come out of my mouth. We have already processed through those things. And so if and when it happens, if or when it happens, They're like, oh, okay, we talked about this. All right, let's do this, right? And they already kind of know what the plan is. So I feel like that decreases trauma, inserts trust in both of us. And so I did have a cord prolapse happen, and it was a very dramatic cord prolapse, and I was not even there. She was, her doula was there, and I was leaving my house, and the doula called and said, "Hey, Kim, she's on the toilet and there's like a bunch of cord hanging out." And I'm like, "Oh, great. Did you call 911? And she's like, "No, I called you." And I'm like, "Okay, somebody call 911. Get her on her hands and knees. I'm on my way." So, I arrive at the same time as right at the same time as the paramedics are arriving. So I get in first, right? And so it was just a whole cluster, and I walk in and there's this giant amount of cord out and like 18 inches of cord. And so, I reach in to see if we could push. So it was not ready yet. So I'm like, "Get on the stretcher, let's go." And, we get into the ambulance. They don't have anything for babies. So I'm like, "Get my stuff," So I'm like grabbing my birth assistant's grabbing my stuff to put it on the ambulance. The baby wasn't doing well. So we deliver, like I just had her deliver, got the baby out and resuscitated the baby. We get to the hospital and they're waiting for us, of course. And they're like, by the time we get to the hospital, that baby's crying, screaming, totally fine, like, doing skin to skin. The doors open up and they're like, "This is your cord prolapse? This is the 20-minute cord prolapse?" I'm like, "Yeah, you're welcome. Now I need to go commit myself into the psych hospital because I am unwell and this baby is fine."
Yeah. And I think midwives need to understand that they're human. I mean, because you both have called me and, "Hey, Tracy, I got to debrief this out." You're human. You are absorbing a lot in a short period of time, and what, of course, wasn't expecting it, and it's hard and it's traumatic. But let's also talk about what works really well in those situations are people working together. The midwife working with, EMS, working with the OB or whoever's going to accept in the hospital system. But let's talk about when there's a breakdown of that, Miri. What happens when you have EMS that doesn't like it, that a midwife wants to come on the ambulance, or when we know that they don't have neonatal resuscitation?
Yeah, I mean, I think it's a huge problem because EMS has their protocols, their training, and to be fair, EMTs are very basic. It's a very basic training. I know and love lots of EMTs, but it's very entry level. And then you've got your paramedic that, yes, can push drugs and stuff, but what they're dealing with most of the time, and I just had a transfer, so I was just chatting with the paramedic after. He's like, Narcan, 5, like so many times a day. He's like, "I never deal with babies." They're genuinely scared of it. And because they don't see it very often and they don't get given any training in it really, which is really sad and frustrating for us midwives because you're terrified of something you don't understand. They know, basic CPR, infant CPR, they don't have neonatal resuscitation, and it's completely different. So they're completely out to sea when they show up. And in their training, they are taught to take control of the scene because most of the time they're showing up somewhere where there is not another medical professional there. So they are the highest level of care. So they're taught to just take over. When they walk into a situation where there's a midwife there who is the highest level of care till she hands off to the NICU or, the OB, they don't understand how to handle that situation a lot of times because in their minds, they need to show up and take control because they're coming into a home birth where there's a lay midwife and she doesn't know what she's doing. Right? Most of the time, that's what they think.
Right.
And so they're going to look around the room and just go, "This is what I know. And so this is what we're going to do. And you're going to listen to me." To be fair to them, I mean, I just had a very difficult situation with that paramedic. And he was saying, well, I could get fired because this is out of my scope. And I'm like, I understand that you have a scope you have to work within, but I am the highest level of care for this baby. And if you showed up to a heart attack and there was a cardiologist there, like, you wouldn't transfer down to the EMT. You would listen to that doctor who was on scene. But it's such a unique situation because they don't show up to like people's homes and there's a specialist already there, right? So this isn't a situation that they come across very often. And so when they don't really recognize what we do and they don't have any training in what we do, they just default to, oh, I am the highest level of care here. And so that's where the tension comes in, because you've got a midwife that knows blow-by is not going to do crap for this baby, and EMS guy who that's all he knows to do. And that's what he wants to do because it's in his scope and that's all he knows to do. And he sees a baby that's kind of crying and that's all he cares about. He hears the baby making noise and he's like, okay, I got to get this baby to the hospital. This baby's low on oxygen. I'm going to do blow-by. They're not thinking about how that baby still needs to inflate their lungs and they may be in respiratory distress still and all these things because they're not taught NRP. That's where the friction comes in. And genuinely, midwives are calling EMS for an expensive ride. Because we know that they don't really have anything for us when they get there. We need them to get this mom and baby to the hospital. We don't need them to be sitting there trying to get a blood pressure or, like whatever they're trying to do. I had EMS show up one time and they were just desperate to get an IV in this mom. The mom wasn't the patient. The mom was fine. It was the baby. And I was like, don't even listen. And this was a situation that I was actually a doula at this birth, and I was trying to get this mom to the hospital because she was in labor with preemie twins, and she was trying to get out the door and had both twins in her apartment before we could get in the car. We call EMS, and both those babies were in respiratory distress, and I'm doing like mouth to mouth on these babies. I didn't have any equipment. I'm just trying to keep these babies breathing. And I'm like, we just need to go. And they're like trying to get an IV in this mom's arm. And I'm like, these babies are preemie twins. We need to go. And it took them forever to get those babies in the ambulance. I was like, you can leave mom. Like, call another ambulance for mom. These babies need to go. They don't listen, or they completely ignore, or they go silent. The situation I had this week, I'm just advocating like crazy. Like, I'm speaking loudly and I'm talking directly to the person and I'm calling them by their name because I can see it on their chest. And I said, where's my paramedic? Hi, Scott. I'm Miri. I'm the midwife here. This is what I'm doing and you're going to listen to me, and I'm not going to move, and I'm not going to stop doing what I need to do to this baby, and I'm not leaving this baby's side till we get to the hospital. And you can yell at me and get mad and frustrated and all that. But Scott, we can debrief this later. Like, we can talk this out later. But right now, you need to listen to me. And I think if a lot of midwives, if they have never, I come from a place where I advocated a lot for people in the hospital. So I'm used to a bunch of doctors and nurses being like, how dare you say anything? So I'm used to that pressure. But I have been in situations where midwives completely fold and just get completely stressed out. And it's so easy to do. Like, my heart's going a million miles an hour. And you're also trying to take care of, you just went through a situation and now you're having to like argue with people. And it can feel like the most stressful, frustrating situation.
Yeah. Well, there's a couple different kinds of EMS. You've got the ones that come in and they're like, this is my scene now, and this is my patient, and you don't have privileges on my truck. And I'm like, all right, what are you going to do when she bleeds on your truck?
Yeah.
And then,
do you have Pitocin? No.
Exactly. I'm like, here, you can have mine. Call your medical director and I'll go with you and tell you when you need to give it. I don't mind not doing things to the patient, but I need to have my eyes on this patient. You know what I mean? Or you got the other ones who are like with the cord prolapse, I was like, hey, you're going to need to, I told the paramedic who looked like he was 11 years old, I'm like, you need to get ready to intubate this baby. And he's like, you're coming with me, right? And I'm like, oh, yeah, I'm coming with you. Like, they're like, he was terrified, and I'd heard nothing about, you don't have privileges on my truck. You know what I mean? So there's just like there's different kinds of that. You got some that are just like, and the other ones that are like, don't make me do this by myself.
Right. And me being a huge advocate, I think that that's a question that I want parents to ask when they are asking me, well, when I'm interviewing my community midwife or my home birth midwife, what do I ask them? I said, ask them what type of advocate they are, because you are their patient from beginning to end. And that doesn't mean, and I know that this can be a touchy topic per midwife, per community, per state. But my philosophy is if you are taking care of somebody at the beginning, you need to take care of them at the end. And if you're not riding on the ambulance, you better meet that person on the other side. And there are midwives that don't do that. So one of the questions that I always get my students and clients to ask, or even people that I consult with that don't even pay me money to do anything, I say, ask them what their transfer plan is and what their transfer plan is on the other side and even postpartum, because I have known midwives in my very past that when they transferred in, that was it, because their care was just over to somebody else. So I think that that's, some of the breakdown, so a huge advocate, your midwife needs to be a huge advocate from beginning to end, because you're still in their care. I mean, they might be in a hospital that, Miri, you don't have privileges in, right? So you're maybe working alongside or stepping back a little bit, but you're still there for the client or for your patient. And I've seen that breakdown, because where we are and where me and Kim are, you go into the hospital and they're like, oh, okay, this is our patient. Okay, we're good. Y'all can disperse. And they're confused when, you were sticking around. Well, of course they don't, I'm sticking around just because they're, I'm the doula, and they're like, oh, okay, Tracy's not ever going to go anywhere ever. Here she comes again. But like, if a midwife comes in, they're very confused at why somebody would want to stay, because they're relinquished of services or whatever it is. So I see that breakdown too. That can be kind of detrimental to the home birth process too. We've got a lot of work to do. What would you tell parents that maybe was having some big issue, or they thought they were having some big issue, or you thought they were having some big issue? Do you kind of work through it together and just kind of roll with the punches? Have you dismissed people from your care because they got too high risk on you?
Dismissed, not necessarily. Said
or transferred out, I guess.
Yeah. I'm like, well, dismissed to me means like, okay, we're done with the relationship. You have to go somewhere else.
That's a good point. That's a good point.
So yeah, I've had people that have gotten preeclampsia, or to the point where you're like, this is not safe. Like hypertension that wasn't preeclampsia, that was like, this baby needs to come out. You are, we're getting to the point where you've got to have a baby, and I don't feel comfortable doing this at the house. So let's go to the hospital, and we go to the hospital. It's always a conversation. So yeah, there's, of course, been things that, and people need to come into this relationship knowing there's always a possibility that you're not going to have a baby at home, period. Because birth happens, pregnancy happens, preeclampsia happens, blood pressure issues happen, unexpected events happen. So, you can't just, again, home birth or bust. It's not a thing. So yeah, I've definitely had some times where, and again, I don't attract folks that aren't okay with that either. So I can't speak to other practices where I do have friends that are midwives that are like, she just won't go. Like, she's refusing. And I'm like, I don't know those people.
Right.
That is not my people.
Right.
Because everybody comes to me knowing, first of all, I'm a nurse midwife, right? So like, ACOG standard of care is my standard of care, right? And so we're not gonna deviate from that because you want a home birth, right? So they know that there are reasons that we would not be having a home birth, and that you can't necessarily, like, you can dismiss me. You can, say, what would, if you have a baby at home and you don't call me, that is not my problem.
Right. Because there is a balance between respect of autonomy, because that's what we talked about. And we're all three huge on that, by the way.
100%, yes.
But like, Miri, what would have to happen, or what would be, have you been in the situations where you might have had somebody that was like, you're not a good candidate and I am not accepting the risk with you, and they still wanted to not be transferred out of care?
Yeah, I think my clientele is a little different. I do come across that. I have to be really honest with people, and I don't skirt around the fact that we are talking about death. It could happen. It's not something that is like beyond the realms of possibility if we continue to choose some of these things. Like in Washington State, we have very relaxed guidelines, but also our midwives have a very full scope of practice. So it can get sticky. I mean, we can go beyond 42 weeks. And so we can do breech, we can do twins. So you better be a midwife that has a lot of continuing education on that, because your general, medical, like midwife training, like when I graduated, I was doing all these extra trainings on these things if I was going to offer it. If someone comes to me and they say they want to do like a breech birth or a twin birth, and I'm like, the frustrating part for me is I think a breech baby should be born in the hospital, but they don't have that option. Parents are stuck in a situation where they are either choosing a home birth with lower resources than a hospital to just be respected and their autonomy preserved, to choose something that isn't ridiculous. A breech baby can be born vaginally. It's not an absolutely ridiculous request to have that with a trained breech provider, but no OBs are getting trained in it. And so their options are so limited. Same with a lot of VBAC moms, that their options are so limited. Sometimes they've had one cesarean because the baby was breech. And then just because that OB always did cesareans after, one, they were never given the option to VBAC. So now they're coming to me with 2 C-sections, and no one will give them a chance or an opportunity. And I have a lot of empathy for these people. No OB will touch them because now they're high risk. And so now we're not going to give you an opportunity, but nobody's talking to these people about the fact that each C-section carries its own risk. And so I'm just very honest with people. I try and pull what data and what studies we have on things like, VBAC after multiple cesareans, breech birth, twin birth in like community birth settings. And I don't skirt around the risks of it. I think that it could be fun to be like, oh yeah, I'm trained in breech. Like, I'd love to do a breech birth for you, but there aren't real risks to that. So we don't pretend like those aren't real. And we talk about the possibilities that come with that. Some of these moms are very determined, and they read and they look at all of the research and they say, I understand what you're saying to me, Miri. I want to do this.
Yes.
And I'm like, okay, let's gather the team. We will be ready and we will provide this for you. There have been times where a mom goes beyond what I'm comfortable with, and I'm pretty clear about it. If we've got a situation where a mom is refusing to do scans, for instance, like ultrasounds on her twins, I'm not comfortable with that. We're monitoring these babies. Like, we know that there's a higher risk for, stillbirth for one of those babies. And I want to know if baby A is going to be coming out head down. I want to know what I'm getting into so I can prepare, right? So I'm not comfortable doing twins without lots of ultrasounds, NSTs. We're doing all the things leading up to birth. We have, cutoffs for hypertension. If a mom is really riding those lines and we're talking about it, I'm like, you could have a seizure. Like, this is a legitimate concern. And we talk about it, and she's like, I'm not willing to do anything about this. That is, I have to say, hey, I cannot put myself in a situation where my license is on the line for one person when there's tons of women that could use my support and help. So I can't. Yes, you could have a great birth with this really high blood pressure. It's not looking like your labs are still looking good right now, right. But we're on the edge of something here, and I don't want to ignore the rushing train, and I'm not willing to put myself on the line for that. And I would say, as a midwife, my lines have changed over time. But it's tough as a midwife that really wants to support autonomy and the belief that parents want the best outcome for themselves and their babies, and that they're going to make decisions that align with that for that family.
Yeah. But that's a human conversation, and this is where I think you and Kim get it right all the time. Is I accept where you're coming from. I recognize your belief system. And I'm not going to shame you because you've made this decision. We're just not the best people together to do that. I wish the system was a little bit better at that because, and I've seen some midwives do some coercive, emotionally manipulative things too, but you don't have to shame somebody into fitting into your birth box philosophy or comfort therein. Same with an OB that's like, hey, you're having a big baby. Hey, I'm absorbing the risk, or I'm absorbing the risk of whatever the controversial topic is. They just go straight to, well, we just want your baby alive, so the difference there is that y'all are, still saying, hey, I hear you. I'm just not comfortable with that. So how can I help you find the place that you need to be? And I have been guilty of saying, jump ship, find another provider. That was back. Okay. That was 10, 12, maybe 15 years ago. Okay. I've grown since. All right. Because I started realizing when I was doing a lot of coaching with other professions that that's not really fair. First of all, it's not fair to the patient because, hey, that's a privileged place to be. Insurance, lack of access, all the things. But then it's not fair to the provider because, Kim, like you said, you don't know those people. You don't know their history. You don't know, you haven't built the relationship. You don't know what their philosophy is and all those kind of things. So when parents come to their community midwives, there's a lot more that goes into just your title, which I respect, but your title. There's philosophy, there's skill, there's continuing education. I tell everyone that you have got to ask, the big ones, like the hemorrhage, the shoulder dystocia, the things that we always talk about, but nobody ever really thinks that it's going to happen to them. Last episode, Ashley said, my midwife never went through shoulder dystocia, ever. What? Okay. So, and she had ultrasounds inside the hospital. Like, her midwives worked well with collaborating with a hospital, and that's where their patients went. And she's like, well, I guess it was missed. I don't care if it was, you don't go over certain emergencies just because somebody has like a precursor to an emergency. We're not talking about just, hemorrhage just because your blood pressure might be high, right? So I think I want parents to realize, and I hate that it's falling on them. First of all, I hate that a lot of this stuff in the maternity care system or the birth world lays on parents. I hate that. Like, I hate educating them. But I'm only one person. I can do what I can do, because I do think it's providers' responsibility to go through the things that we've talked about today. But I don't feel like you're given a fair shot when people in the inside of the system are just grouping all midwives as lay midwives, first of all. So parents have to break it down to, what are you going to do? What do you consider an emergency? What are you going to do about it? And are you okay with the conversation and the information that you're getting? Because I've had to have some pretty serious conversations when I saw a midwife doing some really dangerous things at a birth, and the very next birth was going to be the same midwife. You better believe I got with my client and said, look, these are the questions you need to ask her and be comfortable with. Have you been over these things? No, we haven't been. We need to go over those things, because some things need to be in the air. We need to clear the air. We need to clear the air. So there's a huge spectrum when it comes to interviewing midwives. Should you even be having a home birth anyway? We are pushing, and I've seen it since the pandemic, pushing home birth and community midwives so hard. The burnout is high. It is high. And I don't think it's fair. I don't think it's fair that doulas and midwives have been in the news and they're just going to be the answer to the maternity care problems and all the things. No, I think that they're part of the answer. I think they're part of the equation, but definitely not the answer. And it's just becoming unhealthy. It's becoming unhealthy. Mm-hmm. And I appreciate y'all so much. You have no idea. Because when somebody comes to me and says, hey, I want a home birth, or I want this, whatever, both of y'all are in my head, and I'm thinking, okay, have you asked this question? Because I know this has happened. And have you asked this question? And have you been honest with your midwife about your belief system?
Right.
And are you taking responsibility for your birth? Are you I don't care. You don't have to take childbirth education with me. You don't have to hire me for your doula, but you need to be preparing.
Yep.
Because it's not just about blowing up a pool and filling it up and lighting the candles.
Right.
And taking the Instagrammable pictures.
Mm-hmm.
And I want to remind everybody that social media can be an illusion. And the 3-second videos or the snippets of pictures that you see could absolutely be staged.
Yeah.
And it not be like that. And Miri, I do appreciate you being very transparent about emergencies and what is happening in your world, because you do give a lens into, hey, it's not all rainbows and unicorns.
And I think a lot of people want to become midwives, and I'm like, there's like a big push, like midwife for every mom, like is a big push right now. And I've had a lot of people in my DMs being like, I'm, becoming a midwife, and there's a big push for midwifery, and I believe that women should have more access to midwives. And I'm like, we have a lot of midwives in my area. I don't really think it's an access issue. It's a burnout issue.
I believe
genuinely.
That for sure. 100%. When we're talking about people want to become midwives, and I'm always being asked, Tracy, why don't you just do it? That's not my calling, y'all. It is not. I learned very early on I did not want to be responsible for 2 people. I am an encourager and a supporter. I will doula everybody in the room. But what are some things, what's some encouragement or, some challenges maybe that you would love to tell other midwives? That not people that want to become, maybe people that want to become midwives, but midwives that are already midwives. What are encourages and some challenges that you would like to put out there?
I think that one of the main things is that we're seeing a new generation of midwives, I think, especially on the CPM level. And a lot of the information that gets passed down is through an apprenticeship model. So they're learning from an older midwife. And yes, that's good. Those people have a lot of wisdom, and we can definitely sit at their feet and learn things from them. But they kind of blazed the trail, and they had to fight to get in. Like they are, I have a lot of respect for how much they had to work to be midwives in the community.
Yes.
But what's happening, I've noticed, is that we're trickling down, misinformation maybe is the wrong word, but we're trickling down old practices and outdated information. And it's not that evidence-based gap is real in home birth midwifery as well.
Yep.
And midwives are getting very comfortable in, this is how I've always done it. And all of us can get into that rut. And so I'm even seeing it with NRP. My big push right now for midwives that are graduating is, if you went and did NRP in the hospital, because you can go to the hospital as a home birth midwife, CPM, you can go to the hospital and get your NRP, but they're using equipment and stuff, and they're talking to people that work in the hospital system. Right. When you have a mom in hands and knees on a carpet having a baby that comes out looking floppy and blue, and you do not have a panda across the room with a full neonatal team and a respiratory therapist, what are you going to do? It's not applicable to the community birth setting. And so my big challenge to midwives is, if you're not doing NRP that is specific to community birth, you need to be doing that. And just because you have NRP doesn't mean that you know how to do it well at home or at a birth center without a whole team around you. Yeah. And I would say the same to CNMs that are getting disillusioned with the hospital. And so now they're like, oh, I'm going to start doing home birth. Well, it's the whole Wild West situation out here. Yeah. And you need to get training. Just because you're a CNM does not mean you have the abilities to do home birth.
That was real for Kim. Kim was like, what is happening? I remember after a couple of births, she's just like, y'all are wild.
Yes. Like when I was a student,
I had done home births before, but like it was not by myself.
Yeah. Yes. When I was a student, we had a CNM come onto the team, and I was a senior student at the time. And of course, all I knew was home birth. And so I was so used to having to be the pediatrician, the respiratory therapist, the OB, all the people in one. And she was like, whoa, this is a lot. And I was like, yeah, it is. And it's not for everyone. And I'm jealous that like CNMs in the hospital can call someone in. I wish I could do that. Like, I wish I could have a whole team fly in and just be there. And so I think just getting real about the major differences at home. NRP is my sticky point. You need to do a community-based NRP. Midwives Untethered is an awesome group, and I did that this year instead of Karen Strange, and Karen Strange is also an awesome option. But you need to get it into your head that it's not the same. And you need to be training and drilling on it. Like it's second language to you. You don't even think about it. It's muscle memory, and you know exactly what you're doing in that moment. And I think my other big thing is, if you're doing community birth, so community birth, home birth, birth center, I don't think that 2 people is enough. I hear 1 person for mom, 1 person for baby. What happens if you need someone's hemorrhaging, baby's needing help, you need someone getting in an IV, you need someone like working on baby, maybe 2 people working on the baby, and mom's needing help as well. I have learned that this year. 2 people is not enough. I'm a 3-person team for life. And
absolutely, yes. I actually get people who don't hire me because I bring too many people.
Yeah. And I got that feedback when I changed my policy. I said, oh yeah, the 3rd person needs to either be another midwife or an RN, because I need to know that they can push meds, and I need to know that they can get in an IV. Birth assist, is great for charting, great for getting vitals, but they are not the people I need.
Mm-hmm.
I'm only one person, so I need a second person that has those skills. And I got a lot of messages saying I would not hire you because you have RNs. And I was like, okay.
Go somewhere else.
Yeah, we need to. That's sad because, and again, it's the perception that home birth, birth center birth needs to be, non-medical. Well, just because somebody's an RN doesn't mean that they're going to judge you for having a home birth, right?
No.
So it's like they're
my
just
nurse
there.
had a home birth. My birth assistant had a home birth.
Yeah. What about you? Wisdom challenges for your colleagues.
So, okay, Miri, you spoke to the home birth midwives. I would agree with everything. So, I mean, I would speak to the people in the system is that, I feel like so many midwives who work in the hospital are just like, feel like their hands are tied by the hospital, right? Like, oh, well, the policy is this and, whatever. I disagree with that. I don't care what the hospital's policy is if it is a safe, a safety issue. Of course, I care about the policy, right? But your patients can have autonomy. Let risk management come and say, well, this is our policy. And then you can say, let's change that policy because that's dumb or that's not evidence-based, right? Like, let's let them come. What are they going to do? Fire the patient because they didn't want an IV, or they wanted intermittent auscultation or, like this, and they qualify for those kinds of things, right? Like your hands are not tied by the system. Your hands are tied because you're letting them do it. So
the hierarchy of power is an illusion.
It's an illusion. Yes. Your patient who has been informed and has been, informed of the risks and the benefits of all of the things has every right and in their power to make the decisions. And you should not be bullying people because your hospital says you have to. That's it. So make better consent forms. Make risk management work for your patients, not for you. I mean, because risk management is not there for you. They're there for the hospital, right? Like they're protecting the hospital. They're not even protecting you. They're definitely not there for the patient. So policies need to change based on evidence-based practice. And if the policy is different and is not evidence-based, then you need to make it that way.
Thank you, ladies. This is so great. Thank you again for sitting down and talking about the hard things. That's what resilience is knowing. Because you don't know what you don't know until you experience it, right? And sometimes we go into these things with rose-colored glasses on, especially newer midwives and especially newer doulas. I just want to be a part of birth. And I'm like, do you though? Do you though?
Do you want that?
So, thank you for talking about some of the heavy stuff because I do know that there are families out there that have gone in very blind and have a lot of questions coming out the other side and which things that they wish that they had known. And I appreciate you both. Busy as all get out. I want to encourage and challenge you both to, make good boundaries, which I've always told you to do, and get some really good sleep and turn off your phones when you can. Yeah. But again, I really respect you both for knowing your limits. That's another thing is midwives need to know their limits, serve their community and their need. But, it's not just about getting continuing education, is absorbing it and then knowing your limits. Mm-hmm. And I just know so many that are not going over and beyond and getting the things that they need. And it's a very good point, Miri, that things are going to change. The 15 to 20 year evidence practice gap. And, that's what I was saying before. I've seen some older midwives not know what to do in definitely the neonatal resuscitation. And I'm like, I should not know more than you.
Because I taught you.
should not know more than you, right?
I'm
Anyway,
taking credit for that.
that's right, Kim. That's right. You taught me a lot. You taught me a lot. But it's, it has to be second nature. You have to live and breathe it. These are lives that we're talking about. So let's just hold ourselves accountable for what we don't know, because it's not all rainbows and unicorns. It's not just about, hey, I want my name posted on Instagram and yay, I'm the best birth worker. That's not what it's about. It's about our families and keeping everybody alive and psychologically whole. And that's a big order. That's a big order. So thanks again, ladies. We'll talk to you soon. Appreciate you.
Thank you.
Thank you.
Thank you for listening to the Keeping Your Power podcast. I hope this episode reminded you that your feelings are valid and your voice matters. If it spoke to you, share it with someone who needs to know that they are seen. You can connect with me at tracidoula.com or find me on social media at Tracidoula. On the next episode, we will talk with a high-risk labor and delivery nurse named Sarah, aka social media name Labor Junkie RN, who shares her heart about supporting her parents' belief system even in a high-risk situation. She also shares her heartbreak when she loses her best friend suddenly and the grieving process. Let's remember that healthcare professionals are human. I hope to see you then. Until next time, keep your power in the process.